Welcome to Chapter 6, Congenital Anomalies of the Cornea and Sclera in the BCSC Cornea External Disease Series. This chapter explores developmental disorders affecting the anterior segment, emphasizing the clinical presentation, underlying embryologic mechanisms, and management strategies for congenital corneal and scleral abnormalities. Let's begin. This table outlines the key dimensions of the cornea, highlighting both normal and abnormal developmental variations. Normal corneal size progresses from a horizontal diameter of approximately 9.5 to 10.5 millimeters at birth to 10.5 to 12.5 millimeters after age 2, with a typical central keratometry value of 43 diopters. Microcornea is defined by a diameter less than 9 millimeters at birth and less than 10 millimeters after 2 years, and is usually associated with a flatter corneal curvature. Megalocornea features a diameter greater than 12 millimeters at birth and over 13 millimeters after age 2, typically presenting with a steeper corneal profile. Cornea plana shows variable diameters at all ages and is characterized by a notably flat cornea with keratometry readings often in the 30 to 35 diopter range. Microcornea is defined as a clear cornea of normal thickness with a horizontal diameter of less than 10 millimeters in adults or less than 9 millimeters in infants. It is crucial to distinguish microcornea from other ocular size abnormalities. For instance, microophthalmos refers to a small globe with associated malformations, while nanoophthalmos involves a small but anatomically normal globe. Ultrasound and axial length measurements are particularly useful in differentiating these conditions. The condition likely arises from fetal arrest of corneal growth around the 5th month of gestation or from overgrowth of the anterior tips of the optic cup, which limits the available space for the cornea to develop properly. From a genetic standpoint, microcornea is most commonly inherited in an autosomal dominant pattern, though autosomal recessive inheritance has also been reported. There is no known sex predilection associated with this condition. Microcornea presents with a range of clinical features that aid in its identification and management. The cornea tends to be relatively flat, making hyperopia a common refractive issue. This anatomical configuration predisposes patients to an increased risk of angle closure glaucoma. Interestingly, open-angle glaucoma has also been observed in up to 20% of affected individuals, even without angle closure. Ocular associations frequently include persistent fetal vasculature, or PFV, congenital cataracts, anterior segment dysgenesis, and optic nerve hypoplasia. These coexisting ocular abnormalities may complicate the clinical picture and influence prognosis. Systemically, microcornea may occur in conjunction with syndromes such as myotonic dystrophy, fetal alcohol syndrome, Ehlers-Danlos syndrome, and achondroplasia, highlighting the importance of a thorough systemic evaluation in patients with this finding. The prognosis for microcornea is generally favorable, particularly when the condition occurs in isolation and associated hyperopia is corrected with glasses. However, additional treatments may be necessary when conditions like amblyopia, cataract, PFV, or glaucoma coexist, requiring a multidisciplinary approach for optimal visual outcomes. Megalocornea is a bilateral, non-progressive enlargement of the cornea that maintains normal histologic structure. It is defined by a corneal diameter of at least 13 millimeters in adults or greater than 12 millimeters in infants. The condition may result from a failure of optic cup growth and incomplete closure of the anterior tips, leading to an excess of corneal surface area. In some cases, it may represent arrested buphthalmos or reflect disproportionate corneal growth. Additionally, abnormalities in collagen synthesis, such as those seen in Marfan syndrome, have been implicated in its pathogenesis. Genetically, megalocornea is most commonly inherited in an X-linked recessive pattern, with males more frequently affected. Heterozygous females may show only mild corneal enlargement. Megalocornea is associated with a range of ocular and systemic anomalies. Ocular findings may include iris translucency, pigment dispersion, and meiosis. Additional ocular associations are goniodysgenesis, cataracts, and ectopia lentis. Arcus juvenilis and glaucoma, though not congenital, are also observed in some patients with this condition. Systemic anomalies can be diverse, involving craniosynostosis, frontal bossing, and hypertelorism. Affected individuals may also present present with facial anomalies, hypotonia, and dwarfism. Syndromic associations include Down syndrome, Marfan syndrome, and Alport syndrome. Other linked conditions include osteogenesis imperfecta and mucolipidosis type 2. It is important to distinguish megalocornea from congenital glaucoma, which presents with elevated intraocular pressure, optic disc cupping, Hobbs striae, and deciment membrane breaks. In contrast, patients with megalocornea do not exhibit increased intraocular pressure or optic disc cupping, but instead they often show signs of pigment dispersion, noted by transillumination defects with or without a Krukenberg spindle. They typically show short vitreous length, a deep lens and iris position, and a normal axial length, which helps differentiate the condition from the ophthalmos. Megalocornea is typically associated with myopia and with the rule astigmatism. From a surgical perspective, considerations include lens instability, subluxation, and iridogenesis. These patients may pose a challenge during cataract surgery due to poor zonular integrity, necessitating careful intraocular lens selection and placement strategies. Cornea plana is a rare corneal condition characterized by an unusually flat corneal curvature, with keratometry values typically between 30 and 35 diopters. A key pathognomonic finding is that the corneal curvature matches that of the adjacent sclera. Clinically, patients often present with high hyperopia, sometimes greater than 10 diopters, and may have peripheral corneal haze or arcus. It can resemble sclerocornea, but the limbal architecture and corneal transparency are preserved. This condition is seen more frequently in individuals of Finnish ancestry. Genetically, cornea plana can be inherited in either an autosomal dominant or recessive pattern. It is associated with mutations in the KERA gene, which encodes keratin sulfate proteoglycans such as keratocan, lumican, and memican. These proteins are essential for proper spacing of corneal collagen fibrils. Mutations lead to altered keratin sulfate proteoglycans, which in turn cause the cornea plana phenotype. Cornea plana is associated with several ocular and systemic abnormalities. Ocular complications may include central corneal clouding, cataracts, and both anterior and posterior colobomas, as well as sclerocornea and microcornea. Patients are at risk for angle closure glaucoma due to a shallow anterior chamber, and in some cases, open-angle glaucoma may also develop due to angle anomalies. These findings often coexist with other conditions, such as sclerocornea and microcornea. On the systemic side, an association with Ehlers-Danlos syndrome has been reported. Management of cornea plana focuses on correcting refractive errors and actively managing or preventing the development of glaucoma. In cases where there is significant central corneal opacity, surgical interventions such as DALC or PKP may be necessary to restore visual function. Now let's talk about sclerocornea, a non-progressive, non-inflammatory condition characterized by scleralization of the cornea. This anomaly may involve only the peripheral cornea or, in more severe cases, the entire corneal surface. Clinically, it is marked by an ill-defined limbus and the presence of superficial blood vessels that span from scleral, episcleral, and conjunctival origins. While the condition is often sporadic, both autosomal dominant and recessive patterns of inheritance have been documented. There is no sex predilection, and approximately 90% of cases present bilaterally. Notably, sclerocornea is strongly associated with cornea plana, seen in around 80% of cases, and often coexists with malformed anterior segment angle structures. Keratoglobus is a rare congenital ectasia of the cornea characterized by bilateral steepening and thinning, which results in a globular corneal shape. Unlike keratoconus or pellucid marginal degeneration, keratoglobus is present at birth, distinguishing it from these progressive ectasias. It has a known association with Ehlers-Danlos syndrome type 4. Further discussion of keratoglobus, including its clinical management and implications, will be provided in Chapter 9 of the BCSC Cornea External Disease series. Developmental anomalies of the cornea and associated anterior segment structures often stem from disruptions in embryologic development. Anterior ocular structures, such as the corneal endothelium, stroma, and iris stroma, arise through a process involving 3 distinct waves of neural crust cell migration, beginning around the 6th week of gestation. Interruption in this finely tuned process can adversely impact the development and differentiation of anterior segment structures. Anterior segment dysgenesis refers to a group of congenital anomalies caused by errors in anterior segment embryogenesis. These anomalies represent a spectrum of defects that can affect various structures, including the cornea, anterior chamber angle, iris, and lens. The manifestations of anterior segment dysgenesis vary in severity and may present with overlapping clinical features. To aid in the evaluation of these developmental abnormalities, high-frequency ultrasound proves to be a valuable diagnostic tool. It enables the detection of subtle anatomical anomalies that might not be visible through conventional clinical examination, offering crucial insights for diagnosis and management. Carefully observe the next slide, which features a video illustrating anterior segment development. A solid grasp of this developmental process is essential for understanding anterior segment dysgenesis.
This animation illustrates the normal development of the cornea, as well as the developmental abnormalities leading to Peters anomaly. Between the 6th and 7th week of gestation, neural crest-derived cells migrate between the surface ectoderm, which will form the future corneal epithelium, and the anterior lens vesicle to create the cornea. The first wave of migration becomes the corneal endothelium. A second wave migrates in the space between the endothelium and the epithelium to give rise to the stromal keratocytes. Lastly, a third wave contributes to the developing iris. One can see here too that these neural crest-derived cells also lead to the sclera. By the 7th week of gestation, the conjunctiva and choroid begin to develop and the globe takes on a more characteristic shape. Here one can appreciate the complexity of the developing eye. If neural crest migration is disrupted, these structures can fail to develop properly, leading to anterior segment dysgenesis. In this schematic, the first wave of neural crest migration did not occur properly, and Descemet's membrane is absent in part of the cornea. Additionally, there are adhesions between the cornea and the lens. This results in the clinical appearance of a type 2 Peters anomaly.
Posterior embryotoxin is an embryologic anomaly that is defined as a prominent and anteriorly displaced Schwalbe's line, which is visible on external examination. Schwalbe's line is a gonioscopic finding that represents the peripheral termination of Descemet's membrane. However, when displaced so anteriorly that it is seen near the limbal cornea, this defines posterior embryotoxin. The image on the right illustrates the classic appearance of posterior embryotoxin. It shows a close-up view of the anterior segment of the eye with two arrows pointing to a distinct, anteriorly displaced Schwalbe's line. This line appears as a curvilinear, white, elevated ridge located just central to the limbus that can be seen even without the use of a slit lamp. When this prominent Schwalbe's line is accompanied by adherent iris strands, the condition is termed Axenfeld anomaly. The trait is typically bilateral and follows an autosomal dominant inheritance pattern. Posterior embryotoxin can occur in isolation or alongside other anterior segment abnormalities. It is commonly associated with systemic or ocular syndromes such as Axenfeld-Rieger syndrome, Alagille syndrome, noted for arteriohepatic dysplasia, X-linked ichthyosis, and familial aniridia. Axenfeld-Rieger syndrome is a condition that merges two distinct anomalies, Axenfeld anomaly and Rieger anomaly, due to overlapping phenotypic features. Axenfeld anomaly is defined by posterior embryotoxin with iris strands attached to Schwalbe's line. Rieger anomaly includes iris hypoplasia, correctopia or displaced pupils, and polychoria or pseudopolychoria or multiple pupils. When these ocular features are accompanied by systemic abnormalities like craniofacial defects, dental anomalies, skeletal and umbilical issues, the diagnosis becomes Axenfeld-Rieger syndrome. The syndrome is usually inherited in an autosomal dominant pattern, about 75% of cases, but can also occur sporadically. Glaucoma develops in roughly 50% of individuals, which can occur either during childhood or adulthood. A key clinical distinction must be made between Axenfeld-Rieger and ICE, iridocorneal endothelial syndrome, which also features iris changes and glaucoma. ICE is typically unilateral and sporadic with irregular corneal endothelium, while Axenfeld-Rieger is bilateral and inherited. This figure depicts the key ocular and systemic findings seen in Axenfeld-Rieger syndrome. The top left image, A, displays the characteristic iris abnormalities, including iris atrophy, correctopia, and pseudopolychoria, which are hallmark features of the syndrome. The profile image, B, highlights maxillary hypoplasia with a flattened nasal bridge, which is a common craniofacial abnormality in affected individuals. The lower image, C, shows dental hypoplasia, evident by malformed and widely spaced teeth. Lastly, the image in the bottom right corner, D, reveals redundant periumbilical skin, a subtle finding seen in this syndrome. Now we'll discuss Peters anomaly, another anterior segment dysgenesis. Peters anomaly is a congenital condition characterized by central or paracentral corneal opacity, also known as glaucoma. This results from a localized absence of the corneal endothelium and Descemet's membrane. Around 80% of cases are bilateral. While most instances are sporadic, both autosomal recessive and dominant patterns have been reported. It is genetically linked to mutations in the PAX6, PITX2, and FOXC1 genes. There are two types of Peters anomaly. Type 1 involves iridocorneal adhesions along with a central or eccentric avascular opacity. Type 2 includes more extensive anomalies such as corneal lenticular adhesions and/or cataract, usually with a central or total vascularized opacity. This type is presumed to arise from a failure in the separation of the lens vesicle from the overlying ectoderm. Interestingly, the same genetic mutation may result in different types in each eye. In other words, type 1 can occur in one eye, while at the same time, type 2 in the other. High-frequency ultrasound plays a key role in distinguishing between the two types, as this allows you to visualize which structures are adhered. This slide visually compares the two types of Peters anomaly, type 1 and type 2, highlighting their distinguishing clinical and imaging characteristics. On the left side, Peters anomaly type 1 is represented. Image A shows a dense central corneal opacity, which is a hallmark feature of this type. Below it, image C is an ASOCT scan demonstrating iridocorneal adhesions, where the iris abnormally attaches to the posterior cornea. In type 1 Peters anomaly, there is no significant lens involvement. On the right side, Peters anomaly type 2 is illustrated. Image B shows a vascularized central corneal opacity, which is more severe in appearance. Image D, another ASOCT scan, and image E, a histopathologic section, both show corneolenticular adhesions, where the cornea is abnormally attached to the lens, a defining characteristic of type 2. These adhesions are typically more severe and may be accompanied by cataracts. Overall, this comparison underscores the more extensive involvement of ocular structures in Peters anomaly type 2 compared to type 1. Peters anomaly is associated with glaucoma in about 50% of cases, often due to malformations of the angle structures and a shallow anterior chamber. Other ocular anomalies that may accompany Peters anomaly include microcornea, aniridia, retinal detachment, and persistent fetal vasculature. Management depends on the type, with type 1 generally having a better prognosis following corneal transplantation, which is a major indication for pediatric keratoplasty. For smaller corneal opacities, an optical iridectomy may be performed. An optical iridectomy is a procedure to surgically remove a small section of the iris to improve light entry and visual axis clarity. Peters plus syndrome refers to Peters anomaly occurring alongside systemic symptoms, such as cleft lip or palate, short stature, external ear abnormalities with hearing loss, and intellectual disability. Additional systemic findings can include heart defects, central nervous system deficits, as well as gastrointestinal, genitourinary, and skeletal abnormalities. Posterior keratoconus is a condition characterized by a localized central or paracentral indentation of the posterior corneal surface. This indentation occurs without forward bulging of the cornea and without significant irregularity of the anterior surface. This differs from typical keratoconus, which involves progressive thinning and protrusion of both the anterior and posterior corneal surface, leading to a conical shape. The thinning in posterior keratoconus can be either focal or generalized, sometimes affecting a large portion of the cornea, and may result in stromal thinning to as little as 1/3 of normal thickness. Most cases are unilateral and sporadic, but when congenital, they are often linked to abnormal anterior banded Descemet membrane. In some cases, it may represent a variant of Peters anomaly, distinguished by the continued presence of deciment membrane. Clinically, posterior keratoconus can present with pigment deposits and guttae at the lesion margins, along with subtle anterior surface irregularities that cause irregular astigmatism and amblyopia. The image on the right is a slit lamp photograph showing the characteristic posterior corneal indentation of posterior keratoconus. The arrow indicates the site of localized posterior depression, while the bright slit lamp reflexes demonstrate the preservation of anterior surface contour, visually highlighting the contrast with the bulging pattern found in typical keratoconus. This figure illustrates corneal tomography findings found in posterior keratoconus, which demonstrates temporal paracentral posterior corneal vaulting. On the anterior elevation map, top left, elevation is noted nasally, while the power map, bottom left, shows a nasally displaced corneal apex. In the posterior elevation map, top right, the elevation is more pronounced compared to the anterior maps. The pachymetry map, bottom right, reveals corresponding stromal thinning, indicating loss of stromal thickness, stromal haze, and a crater-like depression in the posterior cornea at the site of thinning. Congenital anterior staphyloma is a rare ocular anomaly in which the wall of the globe becomes ectatic, thin, and bulges outward. It is lined with uveal tissue, which imparts a pigmented appearance. This condition is usually associated with a partial or complete absence of deciment membrane and corneal endothelium, and is non-inflammatory in nature. It is frequently linked to other anterior segment abnormalities, such as iridocorneal adhesions, iris hypoplasia, and lens opacities. While a congenital origin is possible, many cases develop following trauma or infection that disrupts the scleral architecture, allowing the internal pressure of the eye to stretch the weakened area and cause protrusion. The images on the right illustrate the clinical and histologic appearance of congenital anterior staphyloma. The top image shows an opaque, vascularized cornea protruding between the eyelids, with visible engorged vessels overlying the uveal tissue. The bottom histologic section reveals thinning of the corneal and scleral tissues with anterior protrusion lined internally by pigmented uveal tissue. Congenital anterior staphyloma is typically unilateral, although the other eye may occasionally present with anterior segment abnormalities. It has no known familial or systemic associations and is usually sporadic. Patients are at risk of exposure-related complications such as corneal scarring and keratinization, and the prognosis is generally poor due to severe anterior segment damage. Management options include surgical intervention, penetrating keratoplasty, or sclerokeratoplasty to preserve the globe or improve cosmesis. In cases of a painful, blind glaucomatous eye, enucleation may be necessary. This condition can be differentiated from other forms of corneal ectasia by the presence of uveal lining along the posterior cornea. Other forms of keratectasia may arise from intrauterine keratitis, vitamin deficiency, corneal perforation, or post-LASIK changes. We're going to finish off this chapter by talking about several more causes of congenital corneal opacification, including interstitial keratitis, congenital corneal keloid, limbal dermoids, congenital corneal anesthesia, congenital glaucoma, and birth trauma. First, neonatal intrauterine keratitis refers to corneal inflammation and damage caused by infections acquired during pregnancy or delivery. These infections can harm ocular tissues via three mechanisms: directly through the infectious agent, via teratogenic effects that cause structural malformations, or through delayed postnatal reactivation leading to inflammation and further damage. Untreated congenital syphilis is a notable cause of interstitial keratitis, although it does not typically manifest until age 6 to 12. The disease often presents with rapid corneal edema and abnormal deep stromal vascularization near the decimate membrane, with the cornea taking on a salmon pink hue, salmon patch, due to intense blood vessel growth. Over the course of weeks to months, these vessels may empty, leaving behind ghost vessels in the corneal stroma. Importantly, the presence of bilateral interstitial keratitis in either a child or adult is considered highly suggestive of congenital syphilis and should prompt further investigation. Congenital corneal keloid is a rare lesion characterized by reactive fibrous tissue proliferation that presents as a white, raised corneal mass. While it often occurs following corneal perforation, trauma, or surgery, it can also be congenital, in which case it is typically bilateral. This condition is generally not associated with cutaneous keloids, except in Rubinstein-Taybi syndrome. It has notable syndromic associations, including Lowe syndrome, Rubinstein-Taybi syndrome, and ACL syndrome. Congenital corneal keloid may also occur alongside cataracts, anterior, and glaucoma. Histologically, it is distinguished by thick, haphazardly arranged collagen bundles and focal areas of myofibroblastic proliferation. The accompanying image shows a dense, elevated white corneal mass consistent with a keloid, illustrating its opaque and irregular surface. Limbal dermoids are benign congenital tumors that present as raised fleshy lesions, which may contain a variety of tissues such as hair, sebaceous glands, sweat glands, muscle, bone, or even teeth. They can vary widely in size but are most frequently found at the inferotemporal corneoscleral junction and are typically unilateral. In some cases, these lesions may extend toward the central cornea, be full thickness, or involve the entire anterior segment. They are often associated with syndromes such as Goldenhar-Gorlin syndrome, trisomy 8 mosaicism syndrome, and linear nevosebaceous syndrome. Complications primarily arise from visual impairment due to induced astigmatism and amblyopia. The image on the right depicts a limbal dermoid with visible hair shafts embedded in a pale, elevated lesion at the corneoscleral junction. Congenital corneal anesthesia is a rare, typically bilateral condition that presents in infancy or childhood. These patients develop painless corneal opacities and sterile epithelial ulcerations, which can be mistaken for herpes simplex keratitis, recurrent erosions, or even severe dry eye. It is classified into 3 groups. Group 1 is isolated trigeminal anesthesia, often due to primary hindbrain hypoplasia. Group 2 includes cases with mesenchymal anomalies, such as Goldenhar or Moebius syndromes, or familial dysautonomia, also known as Riley-Day syndrome, which is inherited in an autosomal recessive pattern. Group 3 involves focal brainstem signs but no mesenchymal dysplasia. The condition is associated with congenital insensitivity to pain with anhidrosis, or CIPA, and has been linked to mutations in the NTRK1 gene. Management is similar to neurotrophic keratitis care, focusing on protecting the cornea and preventing epithelial breakdown. This includes frequent topical lubrication, punctal occlusion, nighttime eyelid splinting, or permanent lateral tarsorrhaphy in severe cases. Other options include amniotic membrane transplantation, scleral contact lenses, and conjunctival fraps for advanced disease. This slide describes congenital glaucoma, which is caused by angle dysgenesis, including trabecular meshwork compression and anterior insertion of the iris root. It is usually evident at birth or within the first 3 years of life and can be inherited as an autosomal recessive trait. Clinically, it presents with the triad of epiphora, photophobia, and blepharospasm. Key features include buphthalmos, an enlarged corneal diameter greater than 12 millimeters in the first year of life, and corneal edema. Corneal edema is caused from endothelial dysfunction as a result of elevated intraocular pressure, and it is present in roughly 25% of cases at birth and in 60% by 6 months, with severity ranging from mild haze to dense opacity. Another hallmark is Hobbs striae, which are horizontal or concentric decimate membrane tears from corneal stretching, distinct from vertical or oblique tears in birth trauma. The accompanying image shows corneal Hobbs striae indicated by arrows. Lastly, birth trauma refers to injury sustained during delivery, often occurring in cases of prolonged vaginal birth or when assisted by vacuum extraction or forceps, as these methods can increase pressure on the infant's head and eyes. This pressure can cause progressive corneal edema in the first few postnatal days, frequently with vertical or oblique posterior striae. It is due to rupture of the decimate membrane and corneal endothelium, leading to edema, which subsequently heal with a hypertrophic ridge of decimate membrane. The left eye is often more affected due to the typical left occiput anterior fetal position. Edema may resolve or recur later in life with risks of high astigmatism and amblyopia, and congenital glaucoma remains an important differential diagnosis. The accompanying images depict periorbital bruising from left-sided birth trauma and corneal edema. Congratulations on completing Chapter 6. In this chapter, we explored congenital anomalies of the cornea and sclera, examining both their clinical presentations and underlying pathology. We reviewed conditions such as micro and megalocornea, posterior keratoconus, Peters anomaly, and Axenfeld-Rieger syndrome, congenital anterior staphyloma, limbal dermoids, and other congenital corneal conditions. Key points included their characteristic findings, common laterality, systemic associations, diagnostic distinctions, and implications for vision. This chapter provided a foundation for recognizing these rare but important entities, understanding their potential impact on ocular development, and considering appropriate management strategies to optimize patient outcomes. There are 10 questions with answers that will follow to test your knowledge on this subject. See you in the next chapter.